Welcome to the checkup. I am Aurora Aguilar, editor of Modern Healthcare. The trust between provider and patient has long been a point of contention. A history of marginalizing some communities and less than stellar representation within clinical ranks created rifts that only now are being addressed. This has become top of mind for providers and payers as the well-being of communities becomes not just a hope, but an imperative. But even the most progressive and advanced organizations struggle to connect with patients who might need an array of services outside the walls of a clinic or hospital. Our guest today is achieving great results in this area with an innovative strategy. Dr. Shreya Kangovi is the founding director of the Penn Center for Community Health Workers and an associate professor at the University of Pennsylvania Perelman School of Medicine. Welcome to the checkup, Dr. Kangovi.
Thank you so much.
Thank you for joining us. So for those in the audience who might not know this terminology and who this person is, tell us who the community health worker is.
Yeah. Well, community health workers are a broad umbrella category, which also includes promotoras de salud and community health representatives. And they are essentially trustworthy, I don't use the word trusted, trustworthy individuals who share life experience with the people they serve. And I use the word trustworthy instead of trusted because trust is not automatic. You trust somebody when they are a good listener, when they are empathic, when they put your needs above their own agenda. And that is something that you will find among community health workers as one of their key traits. And so these individuals they are part of a U.S. Department of Labor recognized workforce. They've been around for 80 years, hired by, food pantries and churches and public health departments and increasingly healthcare organizations. And what they do essentially is meet people literally where they are. They get to know each person as a person and they say, Aurora, what do you think you need in order to live your best life? And they do that, whether it's planting an urban garden, battling an eviction notice, helping you get good information about the COVID vaccine or connecting you to high quality primary care.
You get a prize just for saying my name correctly for the first time in my professional career. So thank you for that. So talk about how they're integrated into the center that you created and what role they play.
Yeah, so as you mentioned, I lead the Penn Center for Community Health Workers, and our mission is to advance health equity through effective community health worker programs. And so this center is literally all about community health workers. When I first started doing this work about a decade ago, I partnered up with a colleague who's still one of my colleagues and closest friends, a woman named Tamala Carter. She herself is a community health worker from Southwest Philadelphia. And the first thing we did was actually go out on porches and bedsides and shelters and talk to people who had lived expertise of health inequity, people who living in high poverty neighborhoods. And we asked them, what makes it hard for you to stay healthy and what should we be doing differently? And we took all of the input from these people, as well as lessons from history, to design a best in class community health worker program called Impact. What we were trying to achieve with Impact is, most of your audience by this point has heard of who community health workers are, and they've heard, these magical stories of, trust and getting somebody's electric cut back on so they don't have to go back into the hospital, or, just taking somebody bowling to restore joy after a traumatic situation. And so we'd heard these stories too, but we wanted to ask ourselves, how do you do magic with consistency? How do you set community health workers up for success every time? And so that's what we tried to build with Impact. It turns out that you have to do a lot of things right in order to achieve that magic. You have to hire the right people. You can't do this work just with a training lens. You have to start with the right people who are trustworthy and who have that shared life experience that I started talking about. Then you do have to train at all levels, community health workers, their supervisors, the directors. You have to solve for the balance between the clinical integration. We want community health workers to be a part of care teams, but we also want them to retain that grassroots identity that really defines them. And then you have to design work practices that allow them to meet patients as people, not checklists. This isn't a screen and refer platform. This is about getting to know people and asking them what they need in order to live their best life and doing those things. And then you need infrastructure, supportive supervision, salary, career ladders, and things like that. So we designed Impact as a best practice model to achieve some of that. And I'll pause there and just see if you have questions about that, and I can talk more about what we've done with it and the results.
Well, that's what I was going to ask you, is just the results. So I can imagine that this would have a great impact on especially patient populations that haven't historically had a trusting relationship with their provider. So talk about the results a little bit.
Yeah, absolutely. I mean, the idea, behind the workforce has tremendous face validity, but we wanted to really test this like rigorously, because one of the things that we learned is that community health worker programs aren't new. They've been around for 200 years, and they're pretty tricky to get right, even though the idea is a no-brainer. So we wanted to be like, is this thing really going to work? So we've tested it now in 3 separate four randomized control trials across all sorts of patients, different conditions, different settings, inpatient, outpatient, and we've seen consistent results. It improves quality of healthcare, CAHPS and HCAHPS, as well as access to care. It improves actual health outcomes, things like chronic disease control, mental health, patient satisfaction, and it improves cost of care. It reduces hospitalizations by 65%. And we recently published a study based on these RCT findings that showed that it returns $2.47 for every dollar invested by the payer within the fiscal year. So these are powerful findings. We're starting to see these replicate in places outside of the Philadelphia region where we first started doing this work. So we're moving the triple aim. There's durability of these results. And so on the basis of some of these findings, we are now looking at national scale. We've built programs not only in Philadelphia, but across 20 different states.
You've also had the center train CEOs on some of these issues. So can you talk about what those trainings look like and what kind of results you've seen from that interaction with the CEO directly?
Yeah, absolutely. And I'm really glad that you bring this up because a lot of times, your listeners may be thinking about community health workers as just purely a service workforce who work with the victims of injustice and inequity, if you want to think about it that way. But when you think about what is health inequity, right? Health inequity is a psychological condition that starts with people who have privilege. Those of us who are privileged, we become susceptible to psychological distortions, whether it's racism, xenophobia, greed, and those distortions make their way into our policies, which then affect, the distribution of power and resources within our institution or even across society. That affects living conditions and behaviors and health. So there's a chain reaction that ends with the patient, but it starts with leaders. So we wanted to ask ourselves, how can community health workers not only solve for, the right-hand side of the equation by coaching people and getting them ride tokens and, helping them live their best life, but how can they go all the way upstream and really intervene at the root cause of inequity? So we designed, Ashley Harris, who's a community health worker colleague of mine, and myself and a couple of other team members, designed an executive education experience that's really geared for like the C-suite of a healthcare organization, health plan, provider, it doesn't matter. And the way that it works is that, it's a small group experience where 5 C-suite leaders are paired up with 5 community health worker mentors. And there's a combination of like one-to-one and also these small group sessions. They get to know each other's stories, which is the starting point, and that's incredibly powerful. I can talk a little bit about that. And they use that to sort of then explore like, well, why are our stories so different? Why are the community health workers talking about having been homeless or losing somebody to violence or, facing economic hardship? And the C-suite is having a really different lived experience. What are these structural forces that shape our lives? And then, taking it from there to kind of discussing what is the psychology of racism and injustice? Like how are we unknowingly or, maybe knowingly perpetuating these systems that benefit some people while they oppress others? And then how can we translate that to what's going on in our organization today. Take that journey all the way to what are the problems that we might be seeing within our institution, and how can we redesign explicitly with a lens toward equity. And the CHW is a coach and a mentor to the execs throughout that whole journey.
So one of the things that could come up, especially when there is that vast difference in the life experience, is the language that's used. So microaggressions is something that I saw you quoted on in a fantastic article in the Philadelphia Inquirer. So talk a little bit about how you're sort of coaching, or what the center is doing and the community health workers are doing to coach providers, maybe not C-suite executives since they're not seeing patients directly, but to coach them about, sort of speaking in a way that doesn't turn people off and gets them involved more so.
Yes, absolutely. I mean, I think I'll just speak from my own personal experience. Like, I have been mentored and coached and humbled by community health workers, for the past 10 years. I think of myself as like this woke, enlightened provider and leader, but, all of us have a lot to learn. And I think community health workers are not only lived experts, but they have this kindness and compassion about them that allows them to coach without shame, without shaming. And I think that's really important, right? Like, it's pretty, like, this is thorny stuff. And even though we're starting to talk about it more and more, a lot of providers, a lot of clinicians, a lot of leaders, will have a limited amount of attention or ability to engage with this before it gets so uncomfortable that they become defensive and walk away. So the first kind of thing is how community health workers approach coaching and mentoring of clinicians to be more socially just in their language and actions. And they really take this approach that is empathic and compassionate. And then there's the what, they coach on language, because language matters, So for example, I've definitely heard of stories where, a patient has expressed to a community health worker that they feel upset about the way that they've been treated by the front desk or by a provider. And, the community health worker will, advocate and sort of comfort the patient from that stressful situation, but then also, again, gently take somebody aside later and say, can we talk about that interaction a little bit, and, how it might have come off, and just give people some gentle feedback about, the kind of approach that they're taking. Sometimes that's effective. And sometimes you need to go even further upstream and make substantive changes. And so it's a combination of both. They're solving the problems they can at the patient's line of sight. But the beauty of this executive education experience is that sometimes you just have to hire different people. You have to close that diversity gap. You have to change your compensation practices. You have to look at your real estate policies so that you're not perpetuating gentrification. And it can't just be solved by, language and microaggression fixes all the way at the other end of the spectrum.
One of the reasons why this expertise is so important and should be kept as something special is that lived experience and that sort of, what they bring to the table, the community health workers. And you recently tweeted that a lot of them don't want to be promoted. They want to be promoted within their own profession, but they don't want to necessarily move out of their profession into clinical work. And so talk a little bit about the sophistication that role brings to the entire care delivery team, and how we might be able to fold them into reimbursement, which is always a big deal for any kind of social determinant of health work.
Great, fantastic question. So I'll talk first about the kind of career development aspect. It's always nice, over the past 10 years when, folks know who community health workers are, acknowledge them, bring them into the care team. And then it's kind of a bonus where it's like, we need to be thinking about career ladders for community health workers. So that's all exciting and great. But my colleagues and I have noticed that a lot of times that conversation means, well, we need to make sure that if a community health worker wants to be a nurse or wants to graduate and become a social worker, that they have a career path to do so. I find that condescending. It just speaks to how we are delegitimizing certain professions. Like being a community health worker is a profession, and it's a really important one. And there's, like you said, so much sophistication and wisdom and leadership in this profession. This is not a service workforce alone, not that there's any problem with that, but this is a leadership workforce. And so a couple of colleagues and I recently published a paper where we did focus groups with community health workers to ask them, what do you want in your career development? What do you want in a career ladder? What would make you happy at work? And a lot of them said, you know, I want to do this type of work. Like, I'm not looking to be a nurse. I wouldn't have become a community health worker if I wanted to be a nurse. They want to be able to be promoted, you know, i.e. make more money and grow in their profession, but it's not that they want an exit to something clinical. And so we want to, you know, we've designed that within Penn. And I think that's really exciting. That's where we need to kind of make sure that the field is allowed to grow. The payment is a whole nother question, but I want to make sure I answered your first question about the career ladder.
I love that. And yes, if you're sort of thinking about addressing the payment issue within the center or doing any kind of advocacy work on policies, I would love to hear that as well.
Absolutely. So yeah, this is much broader than, you know, our team at the center. We're fortunate because we have a really strong, you know, business model that's based on some of the outcomes we've been able to demonstrate. But when we look at the workforce in general across the United States, there are only 80,000 community health workers in the United States of America. 80,000. There's over 5 million nurses, just to kind of, you know, compare scale. So this is a vastly underfunded workforce. And, you know, historically, they've been paid through a patchwork of grants, you know, or demonstration projects, time limited or population limited demos. And, you know, the word pilot like gives me hives, you know, because we first all want to just talk about pilots when at this point, the evidence and, you know, the workforce has matured, I think, well past the pilot phase. So really there needs to be two things that happen at the sort of enabling federal and state policy level. Number one is there needs to be sustainable financing. And so we are really excited because we've been partnering with Senator Casey's office in our home state of Pennsylvania to introduce legislation that would create additional discretionary funding, you know, through CDC for pandemic response, which I think would really catalyze an upfront investment in scaling up the workforce, but then also an optional Medicaid benefit that would allow states to really, you know, cover the full range of, you know, evidence-based community health worker services. And we've also been having really promising conversations directly with, you know, CMS and state Medicaid agencies, because I think a lot of folks in particularly Medicaid and Medicare are looking to this workforce, and they just know, boy, Medicaid rolls are swelling right now because of the pandemic. Costs are higher than ever. We cannot keep going with the sick care system, and we have to address the social determinants of health. And when we think about like what are the most proven strategies or workforces to addressing the social determinants of health, like all paths point to community health workers. Like that's the thing to do, is hire and partner with this workforce. So, so Medicaid financing is critical, I think, in this space. The second part of enabling policies is that we want quality guardrails, you know, because when the dollars come, there's always a risk that the workforce will actually get totally co-opted or just messed up. You know, it could get over medicalized. You could start to see people who really may not have those attributes that we talked about at the beginning of the conversation, trustworthy people who have shared life experience with those they serve. You could see people who don't have those things maybe take a 2-week training course and become community health workers. And I don't think that will solve for health equity, and it won't produce the results that we've talked about. So fortunately, my team partnered with NCQA, the National Committee for Quality Assurance, as well as a number of other really wonderful community health worker organizations and representatives across the country to develop what quality guidelines could look like. And the NCQA just released that in a white paper earlier this year. So, you know, it points to some of the things that we've talked about, like hiring practices, you know, person-centered workflow, adequate supervision and compensation. And it's going to give a lot of these healthcare organizations who are frankly newcomers to the workforce a sense of how to get these programs right.
Well, we will certainly keep an eye on that and bring you back at some point in the near future to get an update on all of your work and how it's really transforming the healthcare system. So thank you for all of your work, and thank you for joining us on the checkup today. Dr. Shreya Kangovi is the founding executive director of the Penn Center for Community Health Workers and an associate professor at the University of Pennsylvania Perelman School of Medicine. Thank you for joining us today.
Thank you so much for having me.
I'm Aurora Agler, and I appreciate you watching The Checkup.